Thank you very much. Thank you for the kind introduction. It's a again, pleasure and honor for me to be here. What I would like to do in the next 15, 20 minutes is just to take you through a journey about a discovery and what steps were taken in the last almost 20 years to move a molecule and a discovery to clinical practice. These slides represent my conflict of interest. And as a background, we are interested in identifying patient at risk. We're identifying, trying to see who are the vulnerable patient that will end up with acute myocardial infarction and sudden cardiac death. And we realized in the last several years that simple screening of risk factors may not be sufficient, and systemic markers may not be sufficient, including more invasive procedures. And the realization came to the fact that the majority of the patients present with ST elevation and myocardial sudden death do not have underlying significant obstructive coronary disease. And indeed, acute coronary syndrome is a dynamic process that actually occurs in the interface between the vascular wall and the circulation, pointing to the fact that what we need to look at is not actually a structural evidence, but actually a functional abnormalities. That moved me to the endothelium and to 1980, which you can see that in 1980, by coincidence, the endothelium was discovered. And at that time, the discovery of the nitric oxide and the role of the endothelium, which the blood vessel at that time was looked only as a barrier and not a functional organ. And if you take a blood vessels and you hang it in what we call an organ bath, and you pre-contract it with norepinephrine and apply acetylcholine, you have nice release of nitric oxide that causes relaxation. If you take this vessel and you injure it, whether it's going to be chemically or physically, and you repeat the same experiments, the acetylcholine effect is lost, and you have no release of nitric oxide, which mediate this relaxation. For the discovery of this phenomenon in 1980, these three people won the Nobel Prize on the discovery of nitric oxide. And this essential molecule is actually playing a significant role, not only in cardiology, but in many medical fields. What do we know about nitric oxide? That this molecule mediates all these important steps, that each one of them plays a significant role in the progression of atherosclerosis and ST elevation MI, and finally sudden death. Since this molecule mediates so many parameters, it's essential and important to discover the activity of the molecule, not only the level, but is this molecule is actually active and mediate these abnormalities. The field moved very quickly, and about 6 years after this molecule was discovered, the first human experiment was done, and it was done in Peter Gant's laboratory, who infused acetylcholine into the coronary circulation in human. And the normal response should be vasodilatation. However, he reported for the first time what we call paradoxical vasoconstriction or endothelial dysfunction, where the same substance in the diseased artery actually cause almost occlusion of the arteries and lack of coronary blood flow. The next question that was asked later on, he said, is that anything to do with our physiology and our daily life? And set of experiments I'm not going to put an emphasis on show that the majority of our need to increase coronary blood flow, which are exercise activity and mental stress, all this activity, the increase in coronary blood flow is mediated through the endothelium. And you can certainly test it by giving acetylcholine. So several steps were important that these physiological conditions are mediated through the endothelium, and you can actually test it in the human in vivo. And indeed, when you stress the endothelium, as indicated here, whether it's going to be chemically by acetylcholine, bradykinin through receptors, or by physiological measurements such as shear stress or reactive hyperemia, all of them stress the endothelium to release nitric oxide, which mediate one of the parts of endothelial dysfunction, with its vascular relaxation. The discovery that this is can be mediated by other factors led to the interest to discover the effect of endothelial function and to detect it by non-invasive methodology rather than the coronary circulation. And later on in 92, David Salameyer, when he was in John Dinford lab in UK, tried to do the non-invasive assessment of endothelial function by creating reactive hyperemia and measure it by ultrasound. And the way they did that, you can see here there is a basic diameter, then you seize the flow by inflation of cuff, and then you have this response that's called reactive hyperemia measured by ultrasound. This response is a measure of normal endothelial function. So if you have a normal endothelial function, you're going to have this peak of reactive hyperemia. And then later on, studies show that this peripheral endothelial function correlates with the coronary circulation, as shown by Todd Anderson, pointing out two important points. One of them, that the endothelial dysfunction is a systemic disease. If you can discover it in the peripheral circulation and in the coronary circulation, that means that you have a window to the coronaries through the peripheral circulation, but also this is a systemic disease that affects every endothelial cell in the body. And here it's nicely indicated that if you have a normal coronary response, you're going to have also a normal peripheral response. From the coronary standpoint, one of the way we practice in Minnesota, in Rochester, is that if you have a patient in the cath lab that have ischemia or chest pain with normal no obstructive disease, we do infuse acetylcholine into the coronary circulation to see if there is diffuse vasoconstriction. And again, this is not abrupt spasm, but this is diffuse vasoconstriction, which is abnormal and indicate severe endothelial dysfunction. And this is sort of a picture of a typical patient, of 50-year-old female with chest pain. This is her baseline angiogram, and this is her response to acetylcholine in association with chest pain and ECG changes. What have we learned from the patient that we did? We learned that if you do that to this patient and treat them appropriately, you have reduced emergency room visit for chest pain, you improve their quality of life, and we are looking at sort of mechanistic approach. Study by Ronan Rubinstein when he was at Mayo indicate that even if you have a low Framingham risk score of less than 10, you still have significant microvascular endothelial dysfunction, which brings several points. One of them is it's very difficult to detect this patient based on the Framingham risk score. And actually, there are no significant correlation between the traditional risk factor and the endothelial dysfunction. As we knew, it's more common in women, and the risk in men is mainly from a family history of coronary disease. So it's very difficult to detect the presence of endothelial dysfunction based on non-invasive tests currently. Moreover, when we look at the relationship between non-invasive tests and the presence of coronary flow reserve abnormalities and endothelial dysfunction, there is no correlation. So if you have a patient that have incidence of chest pain or ischemia, and you want to check with a non-invasive test, it's very difficult to detect them with the test that we have now. However, we do have evidence of ischemia, and this is studied by David Hasda when he was at Mayo. And the question that we ask, if you have endothelial dysfunction, is it directly mediate myocardial ischemia? In order to answer this question, we administered tracer, sestamib, during administration of acetylcholine, showing that during the episode of endothelial dysfunction, you have actually evidence of myocardial ischemia. Now, this may create several things. First of all, you can look at this as a small ischemic episode of the myocardium, sort of a TIAs of the myocardium. And second, if you do that, is there any consequences for that? And indeed, we know now that endothelial dysfunction is very hard predictor of diastolic dysfunction and heart failure. Moreover, the presence of endothelial dysfunction in young population is a very high predictor of stroke in this patient population. Again, disputing with what's the source of the stroke, and maybe this kind of stroke is more of a microvascular or vascular stroke that we see in the younger population. What's underlying this endothelial dysfunction? It's looked anatomically okay, and study with intravascular ultrasound show that there is no significant detection of significant plaque. Shahar Lavi, when he was at Mayo, looked at the underlying more tissue characterization at the segment with endothelial dysfunction and published that in the same patient, different segments with endothelial dysfunction have different tissue characterization. This study brings 2 points. First of all, that you do have structural abnormalities at the site of endothelial dysfunction, even if you have normal lumen. And point number 2, it challenged the concept of risk factors. Because if you have different segment of endothelial dysfunction with different disease in the same patient, the role of systemic risk factors is really challenged. What does underlying this endothelial dysfunction? When science advances, we know that the endothelium in the vascular wall is undergoing constant repair and injury. And some of this mediated through progenitor cells. And we found out that in patients with endothelial dysfunction, there is a decrease in specific progenitor cells, and so also reduction in the function of progenitor cells. This was actually supported by also studies in New England that showed the same phenomena in the peripheral circulation. So endothelial dysfunction is a state of vascular injury and lack of repair that may lead to the development of a plaque and a vulnerable plaque, and they may lead to progression of disease. And indeed, what we know currently from studies from multiple centers, including studies from Miki Schechter from Sheba, showing that the presence of endothelial dysfunction, whether it's going to be coronary or brachial, all of them are independently associated with cardiac event, even if you index it to any other conventional or biomarkers. It's a systemic disease, and it has multiple presentations, such as stroke associated with sleep apnea, vascular dementia, renal failure, erectile dysfunction, myocardial infarction, and claudication. So if you have injured endothelium somewhere in the body, this will result with this syndrome. And it can be regarded as the risk of the risk factors. And our job is to see if the ability of the vessel to dilate abnormality can actually give us a window to detect endothelial dysfunction and to be able to attenuate all this abnormal reaction. So if we want to move to a clinical practice, what do we need from a test? We need to show that it's associated with coronary. It's a low risk, low cost, non-operator dependent, reproducibility, easy to use and short duration, and reflect reversibility and predict event. One of the devices currently exists is Endopad from Itamar Medical in Israel. And this device can assess, based on the reactive hyperemia, endothelial function non-invasively in the peripheral circulation. The first study showed that the presence of endothelial dysfunction based on this non-invasive device nicely correlate with the coronary circulation. So if you look at the relationship between the coronary endothelial dysfunction and peripheral endothelial dysfunction, there is a nice ROC that shows the sensitivity of the endothelial function in the peripheral circulation to detect coronary abnormality. What's the challenge that? We need to show that it has help with risk stratification, that it predicts event, and the effect of treatment. This is again study from Ronen Rubinstein. Look at the follow-up on patients at Mayo that have endothelial function testing with the peripherally, showing that the presence of endothelial dysfunction with the follow-up of 7 years was associated with significant cardiac event without independently of other risk factors. Some of these events were actually cardiac death in this population, and this is patient with normal endothelial function. How does it add to the Framingham risk score? Mainly, if you look at patients with risk score less than 5 or low, it can help you to differentiate between the low risk and with or without endothelial dysfunction, putting the patient with low risk and endothelial dysfunction almost close to the high risk from event rate on 7 years. Not surprisingly, because endothelial dysfunction is actually, you're looking at the disease. It's not a marker of disease, it is the disease. And it helps us how to identify patient at risk and to treat. So following one of the studies, there is a nice editorial from Peter Gens looking at endothelial function from the individual medicine standpoint. And why is that? If you take patient with no significant disease, this study was done in patients with postmenopausal hypertensive women, and you treat them based on the guidelines, the patient that have improved endothelial function did not have any event. Patients that have similar treatment but they have persistent endothelial dysfunction continue to have event in follow-up. The same thing is for patients that we treat for coronary disease. If we take patients with coronary disease and we treat them with what we call optimal medical therapy, whatever the guidelines tell us to treat this patient, statin, aspirin, beta blockers, ACE inhibition, we're going to be surprised that only less than 50% are actually responded, their vascular bed is responsive and they normalize their endothelial function. So almost half of them continue to have endothelial dysfunction. Does it relate to event? Indeed, the patients that have improved endothelial function have hardly any event in follow-up. Patients that have persistent endothelial dysfunction continue to have event, indicating that it also can serve as a sensitive marker for your success in individual treatment in this patient, not only at baseline, but to follow the treatment if the treatment is successful or not. One of the use for the future may be also to identify patient at risk before they go for coronary angiography. And this study from Japan showed that it can nicely classify patients with and without coronary disease based on their endothelial function peripherally before the coronary angiography. So in summary, one of the potential use of endothelial function peripherally is to stratify the patient better, mainly in the patient with moderate cardiovascular risk. These are the patients who are struggling the most. The low risk has to remain the low risk, and the high risk we know how to do. And this in the very big group in the middle, the presence of endothelial function, which is actually reflecting the disease, can help us stratify the patient to high and low intermediate risk and to help us with aggressive therapy. So in summary, I just want to give you a story how a molecule that was discovered by mistake in vitro in the organ bath through movement into the coronary circulation and the peripheral circulation actually can implement it into our practice. And at Mayo, we actually have an ability to use endothelial function test in this patient and report to the physician if this endothelial function is normal or abnormal. Thank you for your attention.